general gist. There, now we know. Thank you. So no individuals in a position to control conduct of this activity have any relevant financial relationships to declare. That includes any presenters that are going to speak today, as well as members of our planning team. So I'm Adelaide Murray. I am on the planning team. I work at the Center for Excellence or the Community Health Institute or JSI or any other name that you may have heard us referred to by. I'm here with my colleague Paul Kiernan, who's going to present to you here today. Megan Cara and Melissa Schammel from back. Other members of our planning team include Regina Flynn from BDAS, Rebecca Sky from the Foundation for Healthy Communities, Peter Mason in the back from IDN Region 1, and then also Lindy Keller and Molly Rosenbaum, I don't see here yet. So good, change her name, Bishop. So that's us. That's the planning team and your presenters today. If you need the bathrooms, they'll be down the hall and kind of veered off towards the left. We do have some water and coffee on the side. I think we're already run out of water, so I'll try to refill that when I'm talking. And I think those are all the housekeeping items I wanted to say. So welcome to the MAT Community of Practice. We meet every other month on Thursdays. Come together for 2 hours to talk about medication-assisted treatment in New Hampshire, to talk about what we do and learn how to do it better and share ideas and learn from each other and forming community at our community of practice. So the purpose of our community is to promote and support the successful implementation of an integrated MAT approach in healthcare settings. We do that in a variety of ways, including our group meetings. We may have conference calls should we need to on kind of ad hoc topics. We have practice-based resources and tools that we post on our website. We have the email-based discussion group as well as technical assistance. I'll get into all these things a little bit more. So our Google group is fairly active to discuss MAT program development, and how that works is you can email into the group to ask a question, you can respond to a topic, you can share a resource, you can share an event. It's kind of like a listserv, except, yeah, it's more of a discussion. So if you're not a member of the Google group and you would like to be, you can email me here. We do try to add new members that we catch on the sign-in sheet that might not be a member. It's kind of like an opt-out rather than an opt-in, but sometimes we miss you, so if we miss you, just let me know and we can add you in. We are experiencing some questions about people not being able to access the web portion of it. So the way that it works, it comes through your email, but then there'll be a link to access it on the web. And I'm trying to figure out some people that are having trouble to access it on the web. I just say all this to tell you that what you are receiving in your email is all the information. There's not more secret things on the web platform that you're not seeing. It's just that you can't see it there. So I'm still working on it, but if you aren't able to see the web platform, what's coming into your email inbox would be the same thing that you would see there, just to clarify. So resources and tools that can support are available on our community practice page, and then you can also request technical assistance on the website. So for those of you that don't know, it's October 2019, and 2 years ago, in October 2017, the MAT Community of Practice was officially launched. So it is your 2-year anniversary. Congratulations. So what I did, and we were joking, I pulled out this relic. For those of you that signed in today, you can see the difference between where we were 2 years ago in the sign-in sheet and where we were today, so that I could compare and share with you how much the community has grown, which is really exciting. So 2 years ago, there were 24 people that came to the first meeting. Today, we have 53 people registered, and that does not include a handful of people that I heard from this morning or over the course of the last couple of days that said, I did register, but can I come? So our interest has grown by over 120%. And then in the beginning, we had 14 organizations represented in the community. And then, again, just for this meeting alone, we had 29 organizations represented. So, again, over 100% increase. So give yourselves a round of applause for building this community. Happy anniversary. So today what we're going to do is talk about treatment planning for discovery, recovery, and relapse prevention. My colleague Paul is going to lead us through the presentation on that. And then we're going to break into groups and work through a case study and talk about how we would approach this patient in your practice. To talk about the integration of behavioral health, the resources for behavioral health that you may or may not have. And talk about how you would work with a patient that might be in some type of discovery place on some of their substance use, and develop a greater understanding for how to work with that kind of patient in your practice, with your resources. So what we'll do is we'll contrast discovery, recovery, and relapse prevention treatment planning. We will examine discovery treatment planning within a participant's practice care model, and then we will compare treatment planning among various care models. So at the end of the meeting, we're going to come back together and talk about how different types of care models would work with this patient, and then hopefully talk about how we can move and work together and, you know, expand our resources, expand our collaboration to maybe be more integrated or make new partners, find new resources, that type of thing. And we all come back together. So I think that's, yes. Now I'll hand it over to Paul. Are there any questions before I do? Great, we'll get to good stuff.
Thank you. Hey, everyone.
Hi.
Poor Emily, she's probably tired of hearing me by now. Between treatment, community practice, and here we are at MET. So what we're going to talk about is treatment planning based on stages of change, talk about trans-theoretical model, things like that. I don't have a lot of organic thoughts left in my head. Everything is really someone else's. So when I use the language discovery and recovery goals, it's really coming from the folks at ASAM, Dr. David Mealy specifically. So I got to kind of give a shout out to him about that. I think it's a really good way to relate the treatment plans and what kind of treatment plan you're creating, instead of, you know, talking about the stages of change, kind of relating it back to just discovery goals versus recovery goals. So we're going to talk a little bit about the difference between the two, how to kind of identify which, you know, what you're working with and things like that. So we'll get started. Do you have your time? Oh, she's not here. Addie usually keeps the time for me, so I got to make sure I'm moving along. Good treatment planning begins with good assessment. So what are the specific problems that the patient is experiencing? You know, I have highlighted down here, if you're having problems with treatment planning, start by looking at your assessment tool as well as your practice. Oftentimes when we have a problem here, we spend all our time kind of focusing on fixing it here when the problem is actually a step before it. So if we're not getting good information by our assessment, if our assessment is really an obstacle versus a tool to our clinical practice, it's going to create problems. If it's just something that we're like, oh, I got to get through that assessment. If you're looking at like, I have to use this assessment, I have to get information from this assessment in order to create a good treatment plan, you're more apt to get better information that's specific to that patient. You're not just checking boxes. You're also going to be able to develop a little better rapport if you do that kind of MI sandwich. You know, you open with a little motivational interviewing, you get to the assessment, and you close with motivational interviewing. So that's that. So what are the specific problems that they're experiencing? Why has the patient decided to seek treatment now? Okay, and that's oftentimes the one where if you ask that question, they don't have an answer for you. But if you dig deeper and you use some of those MI skills and get to the kind of root of that, you'll get more information. What do they hope to get out of treatment? That's another one a lot of patients will kind of look at you like, I don't know, I'm just here to get so-and-so off my back. My wife's on my case, or my probation officer's on my case, or, you know, DCOF, or whoever it is. And if you ask questions and kind of, you know, open-ended questions and kind of use those MI skills, you can kind of get to the root of the problem. Well, my probation officer told me I had to come. I hope to get him off my back. Well, okay, well, let's talk about how that'll happen. Why did he ask you to come? Well, I've been using it, and I've had positive drug screens. Okay, well, now we're getting somewhere. If you're having a problem with treatment planning, start by looking at your assessment tool as well as your practice. So ASAM criteria dimensions, I'm not going to spend a lot of time on this slide. I think we went over this last time. We talked about the 6 dimensions of ASAM. It's good to get information in all of these dimensions. You know, find out a little bit of what's going on. Particularly, a lot of times you're going to focus with individuals on dimension 4 and 5, looking at readiness to change and looking at relapse potential and continued use potential. We'll talk about this a little bit more later on. We'll kind of cover these throughout the rest of the presentation. Dimensional assessment, what are the patient's problem in each dimension? So when you're doing that dimensional assessment, looking at each dimension and what are the problems specific for that dimension. For example, if the person is having withdrawal symptoms, you know, looking at dimension 1, you know, what's going on there? Are they actively, currently intoxicated? What's going on there? Dimension 4, what are the problems there? Dimension 5, not everyone who has a relapse potential or relapse problem should get the same treatment plan. Okay, a lot of times we're like, oh, it's relapse prevention. We'll just give them that, you know, carbon copy relapse prevention plan we picked up off the copier from the last person who was in here. People use for different reasons. Some people they just really like getting high. I mean, it's that simple. If you read some of that old AA literature, they talk about people use because they like the effects produced by alcohol. People use drugs because they like the effects produced by the drug. Other folks use because they have an underlying co-occurring disorder that's untreated. Other folks use because it helps them fit in, it makes them feel better about themselves. Other people use in order because they think it makes them, better at work, or whatever it may be. Other people have different relapse triggers, relapse cues, things that go on for them. So you have to know a little bit about what you're working with, and asking questions is the best way to do that. I think a lot of times people forget that the patients really have all the answers. We just have to ask the right questions in the right way to get that information. So what are the patient's problems in each dimension? Some patients, they've gone and relapsed so many times that they have like almost this kind of like Pavlovian response to treatment, where they get into treatment and they're already kind of like waiting for the next shoe to drop, okay? So understanding what you're working with, and you won't know that unless you ask the right questions. Understand different stages of change for different problems, okay? I'm in action stage of change as far as exercise goes. I love exercise and like to go for a nice run in the morning. I am totally pre-contemplative as far as eating better, all right? So I'm in very different stages and some problems that are related to, to a similar kind of behavior. We want to assess, where they are for different stages. A lot of folks that come into treatment for substance use disorder are action stage as far as getting their probation officer off their back, but they are pre-contemplative or contemplative at best regarding their use of a substance. A lot of folks are action stage regarding their opioid use, and they are pre-contemplative at best when it comes to cannabis use disorder, okay? And that's a very typical one I know we talk about. When I talk about these stages of change, people know the trans-theoretical model. Okay, I figured. But we're going to go over that in a little bit. But so understanding, what is the problem, what is the patient's perception of the problem, and not taking into our account what we think their stage of change should be, but what their actual stage of change is, okay? And that's really important here. So understanding different stages of change for different problems. If the patient has multiple problems, which are the ones that are most important to them? Which ones are driving the need for the current level of care, okay? So again, understanding where the patient is at. If the patient is saying to you, I really need dental help, my teeth are a mess, it makes me, I don't like smiling, I'm embarrassed to go for a job. Oh my gosh, my phone is never does that, I'm sorry. I'm so sorry. Understanding, where the patient is at regarding which problem they have, and what's going on for them. Which are the ones that are most important to them, and which one they're driving the needs for the current level of care. If they have dental problems, then we say, well, you don't need to address that. You just need to focus more on your on going to more meetings. That's not, we're not taking into account what the patient has going on. So there's the trans-theoretical model for Shasta and DiClemente. You're all familiar with it. So we talk pre-contemplation, really not thinking about change, or not aware the change needs to occur, or maybe kind of aware that the change needs to occur, but just not really interested in doing anything about it or thinking about it at all. Contemplation is more, starting to think about the problem. Hey, yeah, I've run into a couple of jackpots with my substance use or with my drinking and so on and so forth, but I don't really know. That ambivalence that we talked about. Preparation. Yeah, maybe I will stop. My buddy Tom, he stopped using, and I can go talk to him and find out what he did. So, preparing to make some changes, and action is, yeah, Tom said he went to meetings and he talked to a counselor, and that really helped him. Starting to do that too. And maintenance is sustained change. It's more habitual for an individual. They don't think about it. It's not a struggle. They're not, moaning and groaning every day because they have to stay sober. It's just become part of their life. And there are folks that never really kind of make it to this stage. Every day is a struggle. And maybe not even a struggle, but every day they wake up and they're, constantly have to be vigilant that they have to do everything that they can to stay sober. And that's, that's a difficult population, but that's a lot of the folks that you work with. Concept of readiness to change and stages of change are not person-specific. They're problem or issue-specific. So what does that mean? Same thing we've been saying. Okay, it's not the same for each person, and it's nuanced. For each person, there are different places where they can be for different problems. Okay, they come in to see you for their opioid use disorder, and they are action stage, but there are different stages for their alcohol use disorder. different issues. Attention must be paid to these potentially different and co-occurring stages of readiness in order to sufficiently reduce the risk of relapse to addictive disorders. I would add to this, okay? Not only to reduce the risk of relapse to addictive disorders, but to treat those disorders properly. So again, if I have someone who is in action stage for their opioid use, but their cannabis use disorder, they're pre-contemplative, okay? And I say, well, you need to stop using cannabis. Here's a relapse prevention plan in order to help you stop using cannabis. They're going to be like, I just told you I don't want to stop using cannabis. I'm not relapsing, I'm continuing to use. And that's that difference between the two. We talk about continued use potential being the individual has the potential or is continuing to use versus the person is entered in a stage of recovery and they are at risk of relapse. There's a very big difference between the way you treat the two of them. One is more MI focused and one is more action, CBT, some of those skills focused. So understanding, where they are and paying attention to those different, stages that they are with co-occurring problems. And the same may be true for co-occurring psychiatric or mental health problems. They may not really want to address, any kind of co-occurring disorder, mental health disorder, but they're willing to work on their substance use disorder, or vice versa. They want to fix their depression, but they don't want to stop drinking. So, stages, and then you get into real complicated situations because sometimes the symptoms become so intertwined that it's hard to pull them apart and treat one and not treat the other. So you have to work on that motivational piece to understand, to help them get themselves to understand that they need to address the two at once because the symptoms are so intertwined. Understanding variability of readiness to change facilitates more accurate treatment engagement and service matching. Okay, that's kind of what we're talking about. We have someone that we know is pre-contemplative at best, and we go and put them in an intensive outpatient program. It may not be the best fit for them. Sometimes with ambivalence, a less intense level of care is more appropriate for them, so they can resolve some of that ambivalence at a less intense level of care. We're not taking up a spot for someone who might be more appropriate for the interventions at that level of care, and we're not making the patient frustrated and mad at us, and they're going to end up just doing time versus doing treatment. So we want to make sure that we match the prescribed treatment to what's going on with the individual, and assessing where they are as far as stages of change is a really important part of that. So, assessing it from the client's point of view. And again, a patient's motivation may not be what the clinician thinks they should be motivated about, okay? Oftentimes it's like I think I talked about this last time. I did an assessment on someone who had, she had surgery to remove 2 fingers because she had an infection in her arm. And she was, telling me that one of the reasons it's not that bad of a problem is because, she didn't have any scarring on the top of her arm. So those, the distortive thinking, we want to kind of shout at them, hey, you have some scarring, you're missing 2 fingers. That's our perception, but we really have to work within their perception because it's really all about what their perception is. Once we develop a rapport, once we have that relationship with people, we can start introducing things to them. Like, hey, there's been something I've been thinking about. We've been meeting a little while now, and I just wanted, is it okay if we talk about something for a little while? Yeah, sure, that's fine. And you can introduce those things, but we don't want to, put our agenda on the patient, and that's really important. So we talk about discovery goals, okay? So discovery goals versus recovery goals really just matters where they are in those stages of change. So discovery goals are more for folks who are, contemplative, pre-contemplative, maybe preparation stage a little bit. They're more for folks who, aren't aware that they have a problem, or maybe they don't have a problem. We don't know yet, but they are, more geared towards folks who are, kind of further down in that stages of change model. So less ready to change. They may be uncomfortable for folks, and oftentimes they are for clinicians because we're just used to kind of saying, oh, here's your relapse prevention plan. Just follow this plan, and you'll be fine. I don't want to follow that plan because I don't think I need to stop using it. It's not that bad. I only gotten one DWI, and it's, it was kind of stupid. I made a bad choice that night. I don't have a problem with alcohol. I got a police problem. Anyway, you got to go to these meetings and do this because that's all I know how to do. When really counseling is all about the artsy cool part of counseling is really it's really that working with someone where they're at and getting them to come to their own conclusions that are, helping them see things through their own discovery. They're more difficult to make smart. We talk about SMART goals. Please don't make me go down that road. Everyone knows what a SMART goal is. I'm so tired of SMART. They've mixed it all up. Now it's matters. I don't know what it's going to be next. Trans? Anyway, so they're more difficult to kind of meet those SMART guidelines that insurance companies talk about and everyone else talks about. And they can be difficult for the patient to articulate as well as the clinician. So you want to make sure that you're, working with the patient in order to help them articulate that goal in a way. For example, I worked with DWI folks for a long time. Not that long, but specifically with folks who receive DWI, and they'd come in and be like, everyone's telling me I'm an alcoholic, I don't have a drinking problem, but everyone says I'm an alcoholic. I took this mass lab test, and it said I was an alcoholic, and the person there told me I'm an alcoholic, and you did this evaluation, and clearly I'm an alcoholic because they're saying I'm an alcoholic. And it's like, okay, well, tell me a little bit more about this. Well, I'm not an alcoholic. And you say, well, okay, I don't know what an alcoholic is. There's no clinical definition for an alcoholic. So why don't you tell me a little bit about what that means? Well, it's this, it's that, and, okay, so you have this, idea that this is what an alcoholic is, and you're none of those things. No. All right, thank you. No, I'm not. Okay, well, so what are we going to do here? Well, sounds like you want to demonstrate that you don't have a drinking problem. Okay, yeah, that sounds good. So you work on those goals and come to a conclusion that the patient is comfortable with. Yeah, that's what I want to do. I want to demonstrate, I want to prove that I don't have a drinking problem. Okay, well, how am I going to do that? I have some suggestions. Would it be okay if I shared those with you? Yeah, sure. Well, one way is we could, abstain from alcohol for a little while and see how that goes. See what your relationship to alcohol is like. And say, no, I don't know about that one. And then you can have a conversation about that. Like, if I asked you to stop drinking orange juice, could you do it? Yeah, I could do it. Well, what about alcohol? Well, your relationship to alcohol is a little bit different than orange. So then you can go down that road and start working with them. Write me a story with the last 4 times you got in trouble and what part alcohol had in it. So you can work with them where they're at, and if they're not successful, it might mean they can progress through the stage to a different goal. Gee, I didn't realize I can't stop drinking. Like, it's really hard for me, I'm not getting in trouble. I'm not that definition of alcoholic that we talked about in an earlier session, but I'm having these problems. Like, I can't stop drinking. I went to a social function. It was really awkward for me. I ended up having a beer because it was just so awkward. And then you can work on that. Instead of saying to them, well, you came in, you got a DWI, you need to stop drinking for this amount of time, you need to complete this form, this relapse prevention form, and you need to go to 12-step meetings. Because they're going to lie to you, or they're going to do it, and then they're going to celebrate by having a big party at the end of it. So working with someone where they're at, okay, it's a very important piece. And with that discovery, if John figures out, hey, maybe I don't have a drinking problem, but my relationship to alcohol is very different than I thought it was, okay? We're getting somewhere, okay? The patient's not just doing time, they're doing treatment at that point. An unsuccessful treatment goal may create movement through stages of change, okay? It may not require treatment planning dimension 5 as the patient is continuing to use, okay? So again, if we have someone who's in that discovery stage, we're doing motivational interviewing, we're helping them discover what's going on with them. And these are hard with, I know everyone's got cannabis use disorder or cannabis use in the back of their mind, because so a lot of patients are, kind of go back to alcohol as well with MAT folks. Because they're like, well, I don't have any problems with cannabis. My only problem is you, bugging me. But you have to do more work to help them kind of identify what's going on. Recovery goals, these are more familiar. Comfortable treatment plans. Jennifer will identify and demonstrate the use of 4 coping tools to deal with cravings. Jennifer will complete a personalized relapse prevention plan. Whatever it may be. They're easier to make smart. They kind of fit that cookie cutter language. They can be more difficult to make patient-specific, okay? These are the ones that you have patients who have similar problems, so you kind of end up falling into that rut. Treatment planning really is all about finding really good problem statements and beginning with a good problem statement, a very clear, concise problem statement, and it makes the rest of this much, much easier. For patients who are at preparation action stages of change, dimensional 5 treatment plans, we talk about relapse prevention. Relapse prevention is kind of one of those terms that's kind of a catch-all. So I try not to use it as much. But relapse prevention plans are really just, basically action plans. Okay, they're plans that are recovery plans. Any plan that is going to prevent someone from returning to a behavior that they're trying to stop or the use of a substance that they're trying to stop is really a relapse prevention plan. Getting to the problem, which is it? I really don't want to stop using, but my probation officer told me to come here. Which one do you think that is? Discovery or recovery? You can speak up, it's all right. Discovery, yeah, it's the discovery plan. I mean, that's what I would do there. I mean, this is not someone who's like, God, I got in trouble. I've been really worried about this for a long time. I need to stop, okay? I would stop for DWI, and I didn't even feel drunk. I went to the IDC MP, and they're making me do 6 sessions. Discovery or recovery? Discovery. It's more of a discovery kind of place, all right? No matter how hard I try, I can't stop thinking about getting high. Yeah, we can make a recovery goal. I want more information, but it sounds like this person is aware that there's a problem, and they're thinking about not getting high, they're thinking about stopping using. So I would ask some more questions, get maybe a better problem statement there, but this sounds like someone that might be moving or is in action stage. I'd say, tell me more about that. Well, I've done this, that, and the other thing, and I keep using. The problem statement might be, Joe has made several attempts, on his own to stop using XYZ, and has found he can't. All right, the only thing that makes me feel better is drinking, but it's affecting my marriage. What do you think? Recovery, discovery? Need more information. Need more information, okay? But this is kind of it's more of a discovery goal. You're kind of on the fence, you hear stuff like that, I'm like, oh, great, like, motivational delivery, I'm like, that's a really good opportunity to kind of use some of those things. I want to stop drinking, but I don't want to give up my friends who drink. Yeah, it's more of a recovery goal, an opportunity to kind of work with them to do some recovery goals. Okay, I mean, that's a clear problem. Okay, I want to stop drinking, but I don't want to give up my friends who drink. I mean, you maybe add that I find it difficult to not drink when I'm around them, but... I tried to cut down my drinking, but I always end up drinking more than I had intended. I need to find a way to stop. Clear recovery goal, okay? I need to stop smoking pot and drinking while I'm on probation, or my PO is going to violate me. What's that? Okay. Yeah, so this is where it gets a little interesting, and this is where I differ from some folks, where I think you can do some relapse prevention planning. It's like, all right, you want to stop. Let me teach you some skills to stop, and we can work on the motivational piece while we're at it. Because being willing and wanting to are very different things, okay? So, for instance, you want to stop because somebody wants you to stop, that's fine, okay? But, we can work on the wanting part as we do this. So, I don't really want to stop, but my probation officer, says I have to. So tell me what to do, because I don't know how to do it. Okay, well, we can do that, and then at the same time work on some discovery kind of stuff at the same time. Problem statement, all right? So this is really where it all starts. I had made repeated attempts to stop using opioids, and I can't stop even after an overdose last week, okay? It's a clear problem statement, all right? You might know who this is. If you're reading this on a treatment plan, you might be able to say, oh, that's Joe, or that's John, or that's Jane. I tested positive for fentanyl. My probation officer is threatening to throw me in jail if I don't do something, okay? I got a DWI. I really don't have a drinking problem, just the wrong place at the wrong time. I'm afraid to ask for a sponsor because I don't think anyone would want to sponsor me. All of my friends use drugs, and I don't have anyone in my life who's sober. I want to get off probation. I feel helpless and hopeless all the time and just want to lay in bed all day long. And when my wife makes me mad, I lash out without thinking. Sometimes I even break things, okay? So these are good problem statements, okay? You can do some goal setting, some objective setting with these problem statements. What oftentimes people do is they write very minimal information in the problem statement. They'll write a diagnosis, which is not necessarily a problem. For some people, it's a solution. Those individuals who have a mild alcohol use disorder, they somehow avoid trouble, and they drink to kind of deal with their frustrations and their stress. The fact that they have a diagnosis doesn't make a problem for them. What is the problem? What made you write that? If you're writing, the patient is in denial, like this, I got a DWI, I really don't have a drinking problem, all right? Why are you writing that the patient's in denial? What made you write that? Well, they told me this. Write that down, okay? It's important to follow this up with better information, with more specific patient-centered information. I kind of want to go back to this because I think I have a couple minutes. So when you're going through and looking at problem statements, you want to make, I put this all in quotes. A lot of insurance companies like the quotes, like to have patient problem statements in quotes. In fact, CARF insists on this, and they actually insist on the goal statements being in quotes. They want the patient goal in quotes. I at times wanted to tell agencies just put it in quotes, which can make things complicated. A lot of times, problem statements don't have to be in quotes. A lot of people do this. They appreciate that. It can kind of complicate things a little bit, but if they're saying something to you and it's very clearly a well-articulated problem, use it as your problem statement, sure. But make it specific. If you have, I want to get off probation, and you write legal problems, okay, that can mean anything. It could mean they have an active warrant. It could mean anything. Depression, some people will write depression on a treatment plan. That could mean all kinds of different things. It could mean some depressive symptoms that they're experiencing, like dysphoria, because, we know that's with protracted withdrawal, it's kind of a sign of that. Or it could mean I feel helpless and hopeless all the time, and I just want to lay in bed all along. And they do. That's something that needs to be addressed. Okay, that's going to be something that's going to get in the way of their care. Okay. So, working with someone where they're at and assessing kind of, are they ready to make some changes? Are they really motivated to make changes? Or do they need some time to kind of resolve any internal ambivalence? And working with them where they're at, instead of telling them what they need to do, are just kind of the cornerstones of working with folks in recovery, for more, you're working at relapse prevention, and, versus doing discovery and dropout prevention. You're just trying to keep them engaged, okay? Does that make sense? All right, that's it. Questions? Finished early. Comments? For anyone who's, the third edition of the book, the Motivational Interviewing book, is excellent. There's a lot that they added with the third edition from the second edition, so I would recommend that. Also at the, the Training Institute, anyone who is familiar with Stephen Andrew, Motivational Interviewing trainer, excellent training. If you haven't seen him before, he's fantastic. Really kind of help you with some of those motivational interviewing skills in order to apply some of those, discovery goal kind of philosophies and things like that. Really good skills.
And he's the best he is. Seriously, he's really entertaining.
Yeah, absolutely.
He engages you fully.
Yep.
Oh, sure.
Yes.
I know we're going to branch off at some point here, but I'm just curious what other people, how many treatment goals different agencies use. I imagine, I've worked with clients, some of them have 7 different problem statements that we're addressing. Some of them only identify having 3 or 4. Is there sort of a standard that most companies use, and is it insurances definitely want that you found?
Yeah. So a lot of folks, you want a treatment plan or you want to focus on the problem statement that is driving their need for that level of care. So if they're at IOP, excuse me, and they are working on a problem that they're having, and that problem is related to the fact that they don't have a primary care physician, that's a problem that we certainly want to address on the treatment plan, but they don't need to be IOP to do that. Do you know what I mean? Mm-hmm. So there can be ancillary, if you will, treatment problems and plans in place, but, you really want to focus on the one that is driving that level of care. Like they've had repeated, returns to use at a less intense level of care, or whatever it may be. They can have multiple problems, but, the problem that and you want to be specific with people. Like, I reviewed an agency, we were doing like level of care audits, and the patient was sick, like really, really sick, and needed a very intense level of care, needed like a 3.5 level of care, high intensity level of care. And, was basically, I think they found him like unresponsive a couple times as alcohol use disorder. He was cirrhotic or early stage cirrhosis. So it was, you know, he's in a scary place, and I was like, well, this person's clearly appropriate for this level of care. And then when I looked at the treatment plan, it was like, they're going to improve their self-esteem. And I'm like, look at Maslow's like hierarchy of need, and like, that's up here. Like, some of us are still working on this stuff, you know? You know, we want to focus down here. Let's help him get from point A to point B without dying, you know? So you want to look at what are the, you know, what are the needs of the patient, why are they where they're at, and really treatment plan around those, you know? Doesn't mean you can't add a treatment goal around, hey, you know, we're going to get this guy a primary care physician so we can look at the cirrhosis and help him get, you know, get it medically stable as well. Other questions? Wow. I always, because I answered all the questions during the presentation. All right, thank you.
Thank you. Thank you.
So this is pretty simple. What I'm anxious to do here is really set the stage for the discussion you're going to have afterwards. I'm going to talk about low resource practices and high resource practices, and it depends on where you're coming from. If you're somebody who's an MAT provider or in a treatment program that doesn't have a lot of access to primary care people, then you're seeing yourself as low resource in terms of the physical health stuff, and you know, we're looking at the ASAM dimensions, and so you've got a problem there with dimension 3. If you're, correct me if I'm wrong on this, Paul, because remembering all the dimensions, but if you're somebody who's in a primary care practice, which is what I came from, and you're trying to do MAT, then you're looking at resources that you might need in the behavioral health and in the substance use disorder area, right? So you got people way over here who are practicing in rural area of Carroll County. You've got a doc who was doing prescribing of buprenorphine. That doc does not have a behavioral health person around, does not have somebody, it does not have a LADAC, is trying desperately to deal with the problems in his or her community, and what are they going to do? So, you know, keep that in mind, because as we go through this case, think about if you're in that box, what you're going to do. You're still trying to deliver care. And then you got, over here, you've got my old practice, which now has a nurse coordinator. It has a behavioralist to help deal with some of the behavioral problems that people have, depression, anxiety, whatever. Has somebody who is a LADAC who comes into the practice. It has the access to group work. You know, it's all right there, and we know that nobody comes in with just isolated problems that are just in the substance use disorder area, right? We know we're trying to put everything together. And so in my day job working for the IDN, I'm working to help practices develop integrated care. Now, in between here, stay out of the light, we've got people who may have a LADAC in their practice. That would be great, but they don't have a behavioralist. So they have a relationship with somebody in the community, a community mental health center or whatever. If they're part of a F2HC, they're mandated to have a behavioralist there. But many practices don't have behavioralists. They don't have LADACs, but they have a relationship with somebody in the community who they can easily access. Sometimes those people actually come into the practice. Sometimes they have to refer out to the practice. If they're in the practice, they can do a warm handoff. If they're outside of the practice, they have to do a referral, and they're not sure if people are going to actually fall through with that. So, you know, when you start looking at what's high resource, middle resource, sort of low resource, a lot of it depends. Some of it is geographic. Sometimes transportation are issues. Sometimes people can't make it to appointments because they don't have transportation. And so what you need is somebody who can deal with some of those social determinants. You've got people who aren't able to really work with the problems that you've got, that the treatment plan you've got, because their food is insecure, the housing is insecure, they don't have phones, all those problems. In the high resource kinds of practices, like my old practice, there actually is a community health worker. There's somebody who was dealing with those issues. So we have different frustration levels in our attempts to try to deal with these problems based on the resources that we have, but we still need to address the problem, right? We work towards trying to get more of those resources if we don't have them, but we still try to deal with the problems. And so as you go through the case that Paul's put together, start thinking about where you're at in terms of your resources. What would you do if you had additional resources available? How would you work towards getting those resources that you don't have right now? And try to think about where you are right now. Where would you put yourself on the spectrum? That's really all I wanted to say. Just wanted to set the stage for this, case that we put together.
Great. So what we're going to do now is set us up for it. So in your packet of papers, there's one here that says case example at the top. So what we're going to try to do, if we can, is break into groups, kind of by those three categories that Dr. Mason has shown to us. So as you can imagine, low resource, high resource, and somewhere in the middle. I think maybe by to kind of work with the room. So if we have some lower resource practices on this side, higher on this side, and maybe middle people kind of hang out in the back, let's see what happens there. And if we have like one person sitting on either end, we'll work with it. But I have some flip charts here that we'll hand out. And what we're going to do is we're going to work through these questions. We'll give you time to read through the whole case. It's a dimensional assessment of a person. And you'll have time to read through the case and then discuss with hopefully those working in similar resource settings as your own, how you would handle this case. And if not, then we'll kind of see what happens. So let's start first with trying to break into those categories. I'll give you a couple minutes to do that, and we'll see how we're kind of shape it out as we bring the flip charts around.
Well, there, I think it's about. I don't know where I should go. So yeah, I know. And if we end up sure it's not kind of with somebody, we have another idea. But the next couple, on the phone.
You guys over here are all low resource people? Yes?
Addie, is anyone on the phone? Addie, is anyone on the phone? Yeah, no, we're on the phone. So Greg is the intern of your tax provider. That yesterday I was saying we have some providers. Mentoring and that's what they know. I don't know if you want to go with the group, you might go to something to add to what
I'll go over
people are
here.
saying.
You're going to go to the
Yeah.
You're too high, right?
Yeah. Oh, yeah. But I've been told, so whatever. Like, okay, we'll figure it out. It's all good. Yeah. It's really interesting, though. It's kind of fun, like, how are we gonna be nimble and meet this? Middle? Yeah, yeah. It's probably one of like the biggest ones. Yeah.
I think so. I'm just gonna kind
All right, then I think you're in the right place. All right, then.
She's got two of them.
So once you're kind of done reading through it, yes, and they're also on my back from.
Press that button.
Yeah. Okay. Right.
Give everyone a chance to get situated.
That would be great. Okay. Okay, that's fine. And how much time do we have? Okay. Warm here. Usually always cold. Okay. So what we just spent time doing is breaking into small groups, sort of by the resource, how resourced are the practice that you work in is. We had two more resourced groups that have fully integrated behavioral health. They are not referring out for any behavioral health component of this care. Who met on one side of the room. We had a group in the back who's something in the middle. I didn't sit with them. I don't know what they're like. And then and a less resourced group over here is probably referring out for most of the behavioral health needs. And so I think that what might be interesting and helpful is for groups to share how they answered those questions and to see what we can learn from the different groups, just to see how, different resource offices, practices provide this care. Does that sound like a good plan?
Yeah, it might be good to kind of go through each question with each group.
Yeah. Let's go for the first question.
So I guess we'll start over here. I know everyone's gone back to their seats, but the two groups that were here, so for the first question, who completes the assessment of the patient at the highly integrated agencies? Well, what did you guys come up with?
So our Emily that does the initial assessment.
Okay. Quick answer.
Yeah.
It's a closed-ended question.
Yeah, in our group, it was mostly, I think that there's a nurse who does, who might do it, but it was largely that they had the practice, and Emily that within the practice to do it.
Great.
The other group, same thing?
For us, it's sometimes primary care, and then the primary care refers to Emily that.
Okay, so it does the assessment.
So the primary care does the assessment and finds some reason that there might be a need for a SUD assessment?
Yeah.
Okay. All right. And then, where are we now, medium? Emily?
The caveat is we did this 3 times because there was a lot of confusion going on. So we actually had all of those that you just discussed. The medical doctor and or nurse.
Mm-hmm.
Well, the reality was we were all not mediums. We were in the middle, so we're pretending we were.
Okay.
But then after we realized there was after we did the whole thing, then we realized there was an actual case we were supposed to connect. Then I asked Paul for some clarification, because I did it 3 times.
I So you weren't even looking at the case?
That was why it was confusing.
I think,
That is confusing, I can see how that would be confusing.
I don't know that
But
our
we
group
still
was
did
either.
it even after I asked you, and then at the end of doing it, we realized it was the case.
That's hilarious.
Now
Is that not
I
clear?
understand why the answer to the question wasn't helpful.
Well, my question was at the end of the case, but who was reading?
We got the same answer.
Yeah, I didn't change it.
We got the same answer.
All right, well, that's good. That's good, I think. All right. So what about the last as well? Or no integration, I should say.
So mostly it was a nurse,
Yeah. Okay.
primary care, or in my case, OB, the nurse,
Okay.
and then social worker.
Was there any referral out?
Oh, yeah,
Okay.
for everything.
As well. Right. Okay. Yeah, because I mean, we want to account that as well. If you have a nurse who catches something that, you know, you refer out for a SUD evaluation. Okay. Next one?
Okay, so this is, I'm just thinking it through in my mind. So when the nurse does that evaluation, is it according to ASAM criteria, or is it more like, okay, this person needs behavioral health, and for that behavioral health to be reimbursed, you know, they'll do the ASAM evaluation. I'm just wondering about, like, okay, training, and how do we make sure that our officers are capable of doing this sort of thing? Is that level of training needed within practices? I mean, what are people's, they don't,
Yeah.
just, no, I don't mean to put it just on you. Does
Yeah.
anybody want to answer that, even if you have those other internal resources or other, do the medical professionals need it?
I have no idea where residents would get ASIN criteria.
Yeah.
I mean, part of this is the push nationally is to get, you know, addiction training in medical schools and residencies, because it's not there. So then to say, is there ASAM criteria, that's like, it's like answering the questions before reading the case. You know, I mean,
Yeah.
so I don't mean to sound so harsh, but
Yeah.
you know, this is something that's very confusing, you
Yeah.
know, and it takes
Yeah.
some,
I think some of
deeper dive.
those basic SUD skills are helpful too, because I mean, I worked in hospitals and I would go to consults, and I remember going in there and the nurses are befuddled, they can't figure out why this person's in alcohol withdrawal. And, you know, it's like, well, we asked him how many beers he had, and he said he had 3, you know, or 4, you know. And it's like, well, you know, and so you go and assume, and he had, you know, he had 4, but they were the 24 ounce, and he was drinking Steel Reserve, which is double the alcohol of a standard. So, you know, even beyond ASAM, like getting those basic, like SUD, let me ask some other questions. You know, I had a nurse that I treated, she drank medicine, she only had 2. She drank them out of a mug, one of those giant oversized coffee mugs. So, and she would tell you she had 2 Manhattans, and that's it. So, you know, asking those questions and making sure the staff that are doing that initial just
Still
questioning.
one drink if they don't let it go all the way to the bottom,
I
right?
use the same.
And top it off.
I use the same cup, yeah. Sure. So, yeah, making sure, you know, even beyond ASAM, even beyond that, you know, we're kind of starting down here and how those questions are asked by folks who are not necessarily related to SUD fields or trained.
Okay, so going on to the next one is, how are co-occurring needs managed? It's going to end, the question goes on, but let's just say, how are co-occurring needs managed? Do we want to go in reverse order this time?
So it would be referral out.
Yeah, it'd be a referral out.
Or if she, I mean, I work in OB, so if she had primary care in the building, then that would be sort of the next step.
Okay, and some behavioral, both.
Behavioral health is
Yeah.
referred out.
Okay. And the mid-resource group?
Again, we had 2 answers. We had either refer out for a psych consult, or in-house with a PCP if they were comfortable doing like general psychotropic meds or trying some small things, if that was available, so.
With a consult, potentially with psych.
Okay.
Yeah, so we just went with it. We didn't actually answer the counseling part, but we did talk about it would be a referral out, most likely. Because we had a co-located therapist.
Okay, and more resource practices?
Integrated in practice, behavioral health within the practice and can refer for higher needs. Bridging care with referral out to site. Acute intervention group with acute psych intervention group.
until referral, until appointment is available and for the patient, and satellite, collaboration.
And the other?
For us, there's actually 4 organizations, but, one had a psychiatrist that sees folks for evaluation recommendations. 3 have access to nurse practitioners, mental health, integrated, behavioral health counselors, and some even had, community health workers.
Okay.
So I like that in the middle, it's like that answer about the PCP can prescribe, but also the importance of having someone who's trained in mental health, not that PCPs, there are very many competent PCPs with mental health disorders, but someone who can go beyond that.
With mental health.
Well, not, there could be. Yeah, you know what I'm saying. So, that are confident in treating those, and can address that, so. But you want someone to treat the pharmacological part of that too, so. All right, so I guess we'll go the other way now. How does communication work between behavioral health, and the practice? High integration, what did you guys say?
Is that me? Family Health Center has weekly meetings with behavioral health professionals, daily huddles, using staff messaging and face-to-face. MSCAG works in pods, so they can do a little bit more face-to-face, but there's a behavioral health person in each pod. They have integrated team huddles, integrated behavioral health meetings weekly, and NHE meetings weekly. Center for Recovery Management has a huddle right now with each patient and using staff messaging. They're a relatively new program, and the Nadnock family has MAT weekly meetings, face-to-face, and complete team meetings once a week too.
Wow, great, sounds highly integrated.
Yeah.
It's good. And you guys?
So, EHR, a list and flags, pretty comprehensive system. Verbal communication, catch in the hall, warm handoff, as able, weekly case meetings, MAC-specific desktops, and daily huddles, and at the end of it all, multitude of releases to talk to everybody that we can.
Yeah.
All right, thank you.
I think an interesting part of that conversation for me was hearing about a couple things, was just about, the bumping the shoulders in the hallway and how that can build trust between providers and, the team and the importance of that, and then and how it can be more challenging when everybody's more spread out. And then the other piece was about, and this was my own thought, I'll say, just as far as, so many of you are bringing on newly waivered providers and the value of those huddles and things to develop that competency of these new prescribers that we're getting on board, and feeling more confident and comfortable and confident in offering this care. So those were 2 things that sort of popped out for me in the conversation.
Medium?
We, again, went down the spectrum with, if you have an integrated EMR system between providers, because we were a little confused on where the providers were in the beginning. MOUs, again, with ROIs in place, phone, fax, emails, depends on how provider is in.
Well, no, we were just really focused on what you sort of were talking about. So if it's regarding the opiates, the plan's going well. If it's regarding the cannabis, the provider might not need that direct feedback because that's not what they're treating directly.
Right.
It depends on what their view is on that.
And how it would be different if it was, like harm reduction, or if it was true integrated MAT.
I think one of the things that our group with that one realized is this is an important one to pay attention to. Because you have to communicate. There's maybe, depending on the circumstances of the providers, there's not a perfect way to do it, but there has to be an agreed upon way to do it.
Right, right.
And that generally, the practices that are developing don't learn that until they don't have the communication. I'm highlighting that. Work on this.
Thank you. All right, and then no integration, what do we have? How does communication work between behavioral health and the practice?
Well, there's still integration, it's just not right there.
Right.
Yes.
That's true.
I think that one of the things we talked about is it depends on the behavioral health place or person that the patient is referred to. I know in my
Some are
practice,
better
it
than others,
doesn't
is what
really
you're
happen.
saying.
Yeah.
And if it's like mutual aid, I mean, if that's what people can access, sometimes it depends on what their own barriers are for, getting behavioral health care.
Mhm. I know nobody from Laconia is here, and I know that they are not, everybody has external behavioral health. They're getting most of their behavioral health services externally, and there's phone calls with providers to check in, did that appointment happen or not, and then it's a lot of care coordination that not everybody has the resources to do, but it's that sort of that connection prior to that person's next appointment, somebody's calling to check in to see how the behavioral health is going.
That's what Andrea was saying.
Yeah.
That's Elliot. She does a lot of that.
I kind of do a lot of, I do a lot of, being able to connect, I mean, once they're able to connect with, any behavioral health services, be able to get the release of information to back and forth, be able to kind of talk to them back and forth and be able to say, okay, this patient come back or get like weekly updates, things like that, if they're in current treatment and or weekly or whatever, monthly, and then being able to get those updates to, and to stay in contact with their other behavioral health providers to make sure that they're doing okay.
Yeah, yeah.
Well, and
Hard to get
realistically,
reimbursement.
within a fully integrated system, some clients wanted to have an external therapist.
Yeah.
And those, it feels like that's when you really notice the disparity, is when you have that direct face-to-face regarding one patient, and the other patient, you're outreaching multiple times just to, see if the patient still exists in their work. We would see that.
Okay, any other comments on that, communication piece? Okay, so who is doing the continual assessment for the evolving treatment plan of this patient? Which way are we going now? Starting back with you guys? So if you're outsourcing the behavioral health, who's doing that ongoing assessment? Is it the behavioral health, or is, like, for the, I don't know, did your group even talk in relation to the specific case or not? I know.
Yeah, we did.
Yeah, we did, yeah, so.
Is it the same as?
I think our group had some, differences in terms of the practice type,
Yeah.
being a primary care, OB, addiction specific, so, I do my own follow-up treatment plan.
And it's kind of coordination between myself and the providers.
And the behavioral health providers or the, okay, yeah.
And when we had MAP prescribers in our office, they kind of did it.
Okay.
Well, and we discovered that it was, interestingly enough, it was probably both. Both sides were doing a treatment plan and not necessarily communicating about it, so, that, we discovered that the middle is where we really discover all the faults, because when you're in sort of, when I think of this model, if I'm just operating by myself, I don't have to communicate with anyone. If I'm over here in a well-lubed machine regarding communication, that's great. But if you're in the middle, there's a tremendous number of gaps, and that's where the learning curve is the most steep, I believe.
So, yeah, we had put that each individual provider was doing their own at first, and then we kind of go ideally, the therapist would drive the treatment. But then after reading the case, we thought.
What did you think after?
Well, like, at first we were like, maybe the PO, but they're not the treatment provider, so we left it with the therapist. But, if you're kind of not fully integrated, each individual treatment provider is essentially responsible for doing their own treatment plan within their own agency, you know, so.
But communicating progress and things like that back with referring.
I think when we went back and actually looked at the case, because this person was stable on their opioid use disorder treatment, but the cannabis was the kind of problem statement, or the PO was the problem, but
Sure,
the
yeah.
cannabis use not related to opioid use.
Yep.
That probably in this case, it would be more the behavioral health person who was doing an evolving treatment plan, because the opiate use didn't need a change to their treatment plan, it was stable. So, but then the question also, then we got into the, wanting the cannabis card, which they might need from the medical provider, so, and to go back
I
to
just
why.
I threw that in because you hear it so much.
Yeah.
Like, I'm gonna get my card.
So the question went, it went back to the communication issue. You know,
Yeah.
that's even in cases where it seems like there are clear duties,
Yeah.
there's still the need to come together.
And are there still concerns with their opioid use disorder? I think that's something that.
I think that we talked about, and I'm sorry, I'm jumping back into the bottom of the barrel, but, we talked about, a lot about the whole cannabis issue as well, where, you know, we're looking at addiction. She is escalating her use of cannabis. There is definitely a connection between THC and risk of opioid use. She has an opioid use disorder, so, you know, that certainly can be dealt with in a behavioral health setting, and then it'd be nice to have the medical side saying, hey, I realize you have a lot of anxiety, let's talk about, you know, both behavioral health-wise, what you can do with, but also there may be some medical, you know, indications as well to add treatment for that. HB 366 to be announced later. If you don't know that, that's OUD, it's cannabis for OUD.
Mm. Okay. Okay, the group in the front here?
So I think all of the agencies, it was a team approach for sort of continuing to assess, but mostly every program, I think it was Emily Dapp who was responsible to sort of keep the treatment plan updated and communicated. And one of the programs has a quarterly measure that they make sure they update the treatment plan at least quarterly.
Yeah, we talked about that in that group, the requirement to get Medicaid reimbursement. So.
We said the same thing, just a multidisciplinary approach, like a team approach, and then the same thing as far as having the minimum quarterly reviews for funding and for insurance purposes.
Mm-hmm. Yeah. So, yeah, I think that this particular question is less of an issue when you have those weekly meetings and those, you know, and the ongoing connection, the huddles and the alerts and that sort of thing than it is in some of these, in the mixed setting for sure, and the lower resourced areas.
So I'm sorry, we have about 5 minutes left, so I want to make sure we take time to talk about anything. So I think we skipped this one. So we have this question and this question that we haven't touched on.
Okay.
Middleton, excuse me. So if we could just go around and hear from each group on, you know, one of these questions or something that you thought was helpful from this, or, you know, if you want to address whichever question you thought was most pertinent to your group, maybe we could do that instead of.
Or your big aha moment from the conversation.
Yeah.
I think that's.
We start in the middle this time? We haven't started in the middle yet.
Yeah.
Well, I think the big aha for us was kind of what you just said about, like, when you're in the middle, you don't know what you don't have till you need to create it or go look for it, so.
And the communication is clearly intentional. It doesn't happen by chance, you have to make it, so the communication happen, clarity.
Thanks. Others?
I think it was very eye-opening to see how many resources some of us have available just all in-house and to really utilize the resources that we do have, because not everyone has them still readily available. Also, as far as kind of balancing the time and the relationship with the patient, to kind of divide that between different providers or the disciplines, you know, like the provider, the nurse, behavioral health, it makes the patient feel as if it's a holistic approach where everything is being addressed, but it's not kind of giving that burnout or that strain to one specific discipline. So the patient still feels like they're getting something beneficial from their visit.
Thank you.
Yeah, that was good. Me too.
The last two groups? Low integration, the other high integration group.
I'll talk all day, you know that, but I would just say that, we're talking about where are we gonna send this person because we're kind of this low integration. If we don't have resources, that's another whole issue, workforce-wise, who can we call? And then the whole question is, why is the patient coming? And it's really a matter of discovery and recognizing, does she recognize that there's something that she wants to work on? Yeah, she's got a motive not to be put back in prison. But is going to a counselor going to be something she's actually going to do? So really, what kind of bullet points could we kind of take away and be able to present to her to start working with her if we're not able to then send her to a behavioral health person?
Yeah.
So beginning to look at some of the points on that treatment plan, what would that look like? Certainly, she wants to be an RN, cannabis use, you've got to pass the test in a lot of cases, and she wants early probation, so, starting to look at those points.
Well, I knew that this would be illuminating as far as that there's not, we know that there's not one size that fits all for how you do this work in practices, because every practice is different, but this really, to me, was very helpful in sort of figuring out how different it is and how important, regardless, you got to figure out that communication and whether or not it's easier because you're all in one place or, a mixed up, it's one thing for one thing, one patient, another thing for another patient, or if it's all external. You got to figure it out and make it intentional, as Pete said. So,
Thank you.
I don't know if you have any other wrap-up thoughts, either of you.
So I'll just say that our last meeting of 2019 is going to be on December 12th. At that meeting, we'll share with you the schedule for 2020, but the meetings are every other month, I think on the second Tuesday. We'll send it out. Thursday, thank you. Thursday, the other Tuesday. So we'll have that in December for you when you see you then. And then a reminder to utilize the Google group. We have 2 CEUs for MLADAC, LADAC, CRSWs, and 2 continuing nursing credits. Please hand in your evaluation, and then please also hand in your name tags. We have some new name tags. Very fancy. So when you all split into your groups, you still knew who each other was, because your name tags were for you. That was a big aha moment for us. So please hand those in along with your evaluation. Melissa will check you off, and then we'll make sure to get your attendance certificates back out to you once we've checked off that we've received your evaluation.
I do want to encourage the Google group that, it's all of you who are in this group here today.